Hello, I'm Rachel. I'm the Chief Executive of Patients Association, and welcome to our event around partnering with patients and communities. And we've a pretty packed agenda for this session for the next hour and a half, but I'm just going to wait a moment because the numbers are people are just arriving into the room, and then we will get started. We will be recording this webinar. I hope that that's okay. The chat box is there, and Emma, thank you. You're starting off the chat. So if you want to just say hello in the chat, we'll keep the chat box open for a few minutes so that people can say hello to each other and you can get a sense of who else is in the room. And then any questions, if you can ask those in Q&A, because we're expecting quite large numbers and trying to manage in both areas is quite difficult. But we will get to as many of your questions as possible, but we will be following up with any key themes that come out of here. So hello to each other, and hello Georgina from Suffolk and London. So if we just close down the presentation for a second, and if my colleagues can come on camera, we can just quickly say hello to everybody. So I'm just going to go around the camera before we do the presentation and ask people to just introduce themselves. And it's going to be in the way that I can see you on my screen, which will probably jump around the place once I start it. And Helen, can I start with you?
Hi everybody. I nearly said good morning, but no, we have moved into an afternoon. It's been one of those days. It's really lovely to be here. I'm Helen. I'm an unpaid carer from Nottinghamshire, and I'm delighted to be here to talk about some of the work that I've done with Patients Association and the Patient Information Forum.
Brilliant. And Sophie?
Hi, I'm Sophie Randall. I'm Director of the Patient Information Forum. As Helen mentioned, we've been working together with the Patients Association on a project in Nottinghamshire, which we'll be talking about in a bit more detail in a few minutes' time.
Brilliant. And Debbie?
Hello there, I'm Debbie Freake. I'm a Board Director at the National Centre for Rural Health and Care, and I started life as a GP, but I haven't practiced for many years, but I have worked extensively in board roles across Cumbria and Northumberland and Northumbria.
Brilliant. And Lauren?
Hello everyone, my name is Lauren Oldershaw. I'm a Senior Communications and Engagement Officer at Herts and West Essex Integrated Care Board, where I work with Heather, and we're going to be talking about a project today that we've been working on with Patients Association.
Fantastic. And Heather?
Yes, hello everyone. I'm a Public Engagement Manager for Herts and West Essex Integrated Care Board, and as Lauren said, we're going to be talking about some work we're doing with the Patient Association.
Fantastic. Thank you so much for giving us the time. We really, really appreciate it. And I was so excited for this webinar that I joined half an hour early and then panicked my team when I was like, where's everybody? So it'll be really exciting. It's great to see the mixed people coming up on the webinar chat. And fantastic to see you, Tara Mystery, who works with us on one of our panels as well. So because we don't have much time and we have a lot to hear, Sarah, can you share the slides again? I'm going to hand over to Helen and Sophie to tell us a little bit about the project that you've been doing.
Fantastic. Thanks, Rachel, for that introduction. So my slide starts with my life choices because it's a group of people, all with different lived experience, whether we're unpaid carers, whether we are accessing different health and care systems for ourselves. But the most important thing is we all have come together around personalised care in Nottinghamshire and Nottingham City to really make a difference in our community. I was quite cynical when it all started, thinking this was just going to be another tick box, but 6 years in and we're making a real difference. And I think the work that we've done with Sophie and with Sarah really exemplifies exactly what we're doing in Nottinghamshire in partnering with key system leaders to make a difference that matters to us. Could I have the next slide, please, Sarah? Brilliant. So in a nutshell, we were asked to come alongside Patient Association, Patient Information Forum to look at things musculoskeletal and perioperative information. It was a little tricky because they presented this information to us and we're like, this is what we've done and we've done a really great job, and the ICB were really, really happy with what they'd done, and we all took a deep breath and went, oh my goodness, this just is meaningless for us as people that are accessing these services. And actually we pulled it apart quite radically. A lot of the documentation felt very judgmental to us, very like, well, your lifestyle isn't healthy, your lifestyle should reflect this, and we should all fit into these lovely neat and tidy boxes. And actually, as an unpaid carer, looking after a young man with very complex needs, we don't ever fit in a box. And Rachel knows me quite well and knows that I probably couldn't be pigeonholed even if somebody really tried hard to do that. So that was our starting point, and we moved on and we had some really robust conversations around what it was that the perioperative team at one of our local hospitals wanted to put forward. What did that pathway need to look like? How did it become meaningful to the people that needed to use it, not just the clinicians? And we needed to have a real meeting of minds and understand from both sides of different perspectives about where the importance were. One of our real challenges was around measuring BMI before surgery. A lot of us, myself included, really don't like the idea that BMI is used a lot of the time for shaming, but we needed to understand how that felt from a clinician's point of view, and how we needed to bring that together to produce some documentation that I think I'm really, really proud of myself. It's an okay to ask leaflet was developed because actually we all go into appointments, sit there and nod and go, yes, thank you very much. And then we come out and we have a really big long of questions. And it's like, why did I not ask those questions when I'm in there? And we need to change the mindset of clinicians to expect us to ask those questions. There is no such thing as a silly question. There is, if you have them, we need to ask them. And we developed a treatment leaflet as well. Sarah, could you show the next slide, please? And we developed a treatment leaflet that really, really jumps out at people. It's accessible, it's got infographic stuff in there, because actually what was presented to us to begin with was just this long list of narrative that we were expected to absorb, probably at really difficult points in our lives. And I think, we effectively challenged, but I think we developed some real partnership working. There was no power imbalance in the room, but there was absolute working together and coming together to produce a set of documentations and a pathway that I'm really, really proud of. I'm going to hand over to Sophie next to see if she sort of agrees from my perspective.
Thanks, Helen. I think that, it has been a really interesting process. And I think in a way it was good to have Patient Information Forum and the Patients Association there as a sort of impartial communication conduit between the teams that had developed the initial information and the co-production panel, and we were able to provide a guide through that process of feedback and bring people together. And I think that was quite a challenge for some of the clinicians in particular, I think, to come and see how some of the things had landed. And I just think that just shows the value of involving people with lived experience. Could I have the next slide, please, Sarah? So if we think about that summary feedback that we got from the panel, it was that simple solutions really work and that people want brief information in plain English, and that has the most impact. I think one of the other things we found when we started pulling the information from the pathway together was that it was produced in different sections along the pathway, and so the messaging wasn't consistent. So one of the things we were really keen to do with the project was to pull a consistent set of messaging all the way through, because otherwise it's very confusing for people when they're moving between services. It's really important that the information engages people, and I think that comes to Helen's point about making stuff visually engaging, answering questions, and the why. Why should people do something? Because that wasn't always apparent in the information. It's assumed that why is explained. And I think one of the things that we talked about when we were looking at that judgment element, that people can feel very judged on lifestyle very, very quickly. And when there's a power imbalance, it's easier to very quickly feel that judgment. One of the things that came through really clearly was that the tone should be supportive, it should be open, it should be factual, but with the why, so people really understand that and are clear about what the sentiment of the piece is. So that was very, very important, and that came through really clearly. I think using the about me and it's okay to ask, what the panel told us was that could really positively change conversations with their healthcare professionals. Now, about me is a new standard to support shared decision making. It's been used in some other care settings for a while, but it's fundamentally, it says what's important to the patient, how they want to be communicated with, and what is really important, what they want to get across to their health professionals. So Helen, I don't know if you want to come in here and say why that is so important to you and to your family.
Yeah, thanks, Sophie. We've been using an about me for a long time in our household. Having a young person grow up with complex needs, one of my biggest challenges was everybody was always seeing what was wrong with my son, rather than looking at who he was, what was important to him, what matters to him, and actually briefly what is really important that you need to know about him. So we have a one-page profile. I know the Professional Record Standards Body have brought this in now in a lot of places. But in children's services for us, this was quite a standardised thing that My Life Choices has gone on and developed with the Integrated Care Board in more detail to make it fit for purpose for every setting. Now we use that, it goes to hospitals for us. I carry one in my handbag all the time. It goes to the opticians, it goes to the dentist, and it's a real focus on how he wants to be communicated with him, what you really, really need to know about him in order to get him to work with you. Carl has learning difficulties and disabilities as well, so it's explaining that actually his behaviours, although you might be quick to judge because you're thinking he's been aggressive and difficult, that's his part of his communication. And all those things, including, you know, mechanical objects he's got in his body to keep him alive, you really need to know about those. But it means that when we have an about me, we start a conversation about all the things that matter to him. So you need to know that he loves sport, and you need to know that he is more than just what is wrong with him. And that allows us to go without having to retell our story, without having to tell his life history time and time and time again, but with a real focus on, this is who he is. This isn't, you know, he is not what is wrong with him. He is absolutely entirely entitled to and lives his best life that he can.
Yeah, and I think what's interesting about that is that when people have used those about me profiles, they have better conversations with their healthcare professionals. What we hear on the other side from healthcare professionals quite often is they don't know how to start these personalised conversations. They don't know the way into these conversations. Having this simple information in a consistent format allows that it supports that conversation. So we think that's really important, and that was the message that we really heard from the panel. So it's really about using simple tools. So can I have the next slide, please? So what are we doing with this information? Because it's fine to develop these pieces and get them into a state where everybody's happy. The hardest thing is to implement them across systems and we know there are digital systems, there are paper systems, there are different systems in different parts of integrated care systems. So in Nottinghamshire, Patients Knows Best is a digital health record which is integrated with the NHS app. So that About Me template is in the process of being added in to the Patient Knows Best record within the NHS app. Now, it is also available on paper, but the trouble with having it on paper is then it's not added into any record anywhere for people to access before appointments. So while this sounds a really simple thing to do within the Patients Knows Best element, it's actually really complicated, so it's taking a little while to implement, but we're going to get there. Interestingly, I'm sitting in Wales because I've been working on the Welsh NHS app rollout, and About Me has been embedded in that. So hopefully that's something that can move back into England, because I think that would be a really positive benefit for patients. The OK to Ask text and branding is being rolled out in all sorts of services, in appointment letters and emails and wider publicity campaigns developed by the Trust. And that's really encouraging people to ask questions and to think about questions they want to ask before they go for their appointment. Next one, please. The MSK Together leaflet, which Helen has just shown you, was produced with the panel. It's now printed and in use. The health assessment form is a difficult piece, and it was probably the most difficult piece that we encountered. We talked about some of the issues around use of BMI, about why all this information is required when people are going in to see an anaesthetist. But we have worked on a form which has, as well as explaining, you know, getting the required information, it explains why it is needed and when. And it will be used in hard copy, but they're also building that into a care plan within the NHS app, so that people can access that and add content to it as they're going through their journey, particularly while they're waiting for surgery, because the whole point of this is that we don't get people going for their pre-op assessment after an 18-month wait and then being told they need to go away and get fitter because they're too high risk. So next slide, please. So we often talk about evaluating projects, and often I think the evaluation always comes from a system perspective. It's quite often focused on those hard outcomes that the system wants to see, but actually it's what matters to people that's important in evaluating projects as well. So we worked quite closely again with the panel to think about how you do measure shared decision making from a patient's perspective. What is important? When should you do it? Because if you go for surgery, the patient reported outcome measures are 6 months down the line. They're not very well completed, and often people felt really clearly in the panel that that was way too late. So the survey is going to be at 6 weeks post-op. We're also going to try and use it within the alternative pathways as well. So they're going to look at the reach of the materials, so whether patients received them, because we need to know if they're being used, how they were rated, if people felt they supported their decision making, if they were able to access other support services, because that's a really important component, and their overall experience of personalised care. Now, we've used deliberately very simple language and tried to keep this really easy to complete. And actually, I think it was a really good call and shows the value of co-production, that we're using emoji scales rather than words for people to describe their experience. So it is really simple to complete. So Helen, I don't know if you want to talk about the emoji scales, because we had quite a lot of fun looking at those.
No, we really did. I think one of the things that we're all very aware of is that we get so many surveys come through either in paper form or digitally, and we sort of whiz through them, look at them and think actually there's just too much in there, and they're off-putting from the start. We've got enough challenges. We wanted to use visual pictorial imagery as well. We tried to make the survey evaluation form as accessible for as many people as possible. Somebody's asked a question in Q&A around, you know, the whole easy read stuff. Absolutely, we need to work on this. It is something that we've all raised, and the evaluation for us was a step towards that. I guess some reason we never get everything all done at once in the way that we'd like it done, but that's co-production, isn't it? You know, as much as we'd love everything to be ready immediately, it's not always, and we have to be a little bit patient sometimes, but we haven't forgotten about it. So for us, it was about maybe having one sheet of A4 where nice images jumped out at you and you're like, actually, I don't really want to fill in that survey. That gives me a real opportunity to feed back the good, the bad, the ugly. But actually, what we heard from is that patients that had already gone through some of these systems say actually there's an awful lot of good if communication is right, and if it's truly a personalised care journey and with shared decision making that's meaningful, not tokenistic. So I'm hoping that when we get all this together, we're going to have a really great time, you know, pulling it all apart, looking at what our data looks like, and looking at how we can then expand this to other services and other pathways.
Yeah, and I think that point about easy read is really important. I think getting the initial material right was important. Now that is distilled, we can distill it down again. And I would say that certainly that MSK Together leaflet is probably about 25% of the word count of the original, and the reading age is much lower, and the text has been broken up, but there is no reason why that can't now be kind of moved on to easy read, and it's certainly something that we can feed back into the team as well. I think that is the last slide, so I think we're done now. But it's been a great experience in working together, and I think it does show the value of co-production, and it has raised those issues around BMI particularly that the team just weren't aware of, that that there was, you know, so that actually that also needed to be explained about why that was used. And then I think unless you go and talk to people, these issues are not identified. And once you talk, you need to listen and do.
Exactly. Helen and Sophie, thank you. And Sarah, our head of patient partnerships, is on the call as well, and she'll join the chat at the panel discussion at the end, because she was very excited to be part of this project as well. And just a couple of quick questions before we move on to the next panel. So one of the chats saying they can't wait for About Me to be included. They think the addition, you know, it sounds like a brilliant piece of work. And the other just very quick question is the okay to ask tool specific to MSK, or can you actually, do you think it can be used in other areas?
It can absolutely be used in all areas. It's a really, and in fact we know already that they are moving out that wording. It has been used, you know, it's been used in the past, and then we've gone to BRAN and other things that are a bit more complicated, and Helen will tell you that the panel really didn't like BRAN at all. But yeah, that simple okay to ask thing, it can be used in any setting really. It's just really saying it is okay to ask, and think about those questions that you want to ask and what's important to you, what you want to get out of that consultation time, because we all know how valuable, how difficult it is to get a consultation and how short the time is. So it's making the most of that opportunity so you're prepared and you go in with your agenda.
Brilliant. Okay, well, I think we will have time for lots of conversation and questions from the audience, but we'll move on to our next presentation, and this is going to be Debbie talking to us about the work of the Rural Health Network. Hi, Debbie.
Hi there. I'm hoping that my video is working and that people can see me.
We can see you and we can hear you.
Lovely, excellent. So I'm just going to say a little bit about the National Centre for Rural Health and Care today, and some of the work of the parliamentary inquiry and what came up through that parliamentary inquiry that we were heavily involved with. So the National Centre was established in 2018 with, it's got 9 directors, some support staff and a number of supporters, and its mission is to address the inequalities that we see in the provision of rural health and care, remembering of course that the NHS Constitution has a principle of equal access to health and care, not equal provision but equal access to health and care, and that doesn't always happen. Next slide please. So the job of the National Centre is to really shine a light and share learning and best practice so that we can improve design and delivery. And the Rural Health and Care Alliance is a partnership between the National Centre and the Rural Services Network, and that's a member organisation, and it's dedicated to providing news and sharing information, innovation and best practice to those who are interested in and those who are delivering rural health and care. So we have a number of core values, seeking equity of health and care for our rural communities, creating a strong collective voice for those involved in rural health and care, and raising awareness of the challenges faced in rural health and care. Next slide, please. So it was said during the inquiry that if you've seen one rural place, you have seen one rural place. They are all very different in their nature and different in terms of challenges, but there are some commonalities, and just go through some of them. So we see disproportionately older populations in older areas, and that's to do with retirees moving out of cities, and unfortunately young people often moving into cities. And that older population often comes with complex comorbidities, in other words, often complex health problems that they are living with, and that make it a challenge, more of a challenge for the local health and care providers to meet their needs. Rural areas often have fairly poor transport infrastructure and often road infrastructure as well. We know that patients in rural areas take significantly longer in order to get via transport, either their own or public transport, to primary care or to hospitals, and there are obviously impacts on staff as well. They're less efficient if they're covering larger areas and spending a large amount of time in their cars. And I'm sure we've all heard of the issues of carers working for agencies where they're having to actually cover their own fuel costs and cover the time that it takes between clients as well. Digital connectivity, 4G issues, broadband issues has been a challenge. Things have been improving, but there are still real pockets of difficulties in getting good connectivity, and that makes some of the solutions more difficult as well, when technology should be an enabler but is hampered by the connectivity issues. There are often high housing costs in rural areas and poor housing stock. The housing costs are often related to the impact of second homes, but there's also a lack of social housing and adapted housing and other issues such as fuel poverty, lack of mains gas, etc. There may be poor and fewer educational opportunities. There's often a perception that rural areas are very affluent when they're not necessarily, and in particular there are often pockets of significant disadvantage, economic, social and other disadvantage within rural areas that are masked by the greater affluence. The funding for health and care providers doesn't always take account of the higher costs to deliver in rural areas. Sometimes that's to do with the estate. So, for example, needing to have more hospital sites or primary care, surgeries in order to make services more accessible to local people. But it can also be to do with the productivity of our staff moving across large geographical areas, and workforce provision is a real challenge, is a particular challenge. So there's a cost issue, but there's also a recruitment issue, and they're all interconnected. So it tends to be that doctors in particular like to often end up working where they trained. There's more opportunities for their spouses, potentially educational opportunities. There's better case mix within cities that makes the professional life more interesting. And then coupled with that, all the problems of rotas across multiple sites, small team working, and it becomes a vicious circle where if you've got gaps in your workforce and you rely on agency staff, while they may be very skilled, don't necessarily have the same buy-in and commitment and understanding of the local area, and then it's more difficult to recruit. So it becomes a spiraling problem. Next slide, please. I'm not going to go through all of this, and it may be difficult for some of you to see, but there are obviously some issues which are particularly pertinent in inner cities, and others which are particularly pertinent in very rural areas, and we can all find what we want from statistics. But for instance, if we think about ambulance response times, you can imagine that ambulance response times are worse in rural areas, and also that that can be very important for outcome, for instance, in relation to stroke. The incidence of things like diabetes may be much higher because of the older population. And then there are some very specific issues to do with mental health. And I've put down there a couple of which are about younger people, but people will also be aware of mental health issues in relation to farming communities and also fishermen, fisherwomen, and the particular problems and challenges that they face. Remembering, of course, that health-seeking behaviours are often very different in rural areas to inner city areas. Next slide, please. So there was an all-party parliamentary group for rural health and care that was set up in late 2019, and after some delays related to the pandemic, we published the report in 2022. It was a research-based inquiry and also solution focused. We came up with a number of conclusions and recommendations. Next slide, please. So the first recommendation relates to how rural issues are sometimes not at all well illustrated by the current definition. So if I just give a quick example of this, car ownership is often seen as an indicator of relative affluence, and is lower in inner city disadvantaged areas, but of course people there are less reliant on car ownership. So we see car ownership as far higher in rural areas. So it doesn't reflect the particular challenges in relation to transport. We need to look at things with a very specific rural lens. So it's very important to look at the drivers of health inequalities at a greater level of granularity and with that rural lens. So for example, Hexham as a market town is very close to, is only 15 minutes away from Newcastle, which is a tertiary centre, in comparison to Whitehaven, which is a small town, is at least an hour from Carlisle and another hour again from Newcastle, where tertiary services are. So we do need to look with a particular lens and at a very local level. It's very important that we have a workforce that actually understands the nature of living in rural areas, and for that reason we think that there should be specific rural content in every first degree in medicine, nursing and social care, and that there should be rural work experience in every general practice course, and old age physician courses, nursing courses and other courses. Next slide please. Second set of recommendations are related to ensuring that we can deliver services that are suited to the very specific needs of rural places. And that shouldn't be just about health and care policy, but should also be about ensuring that we can rural-proof our other government policies, housing, transport and technology. In order that we can ensure that technology is an enabler, it's really important that there is a rural technology health and care platform and strategy that takes into account some of those particular challenges. And then the final recommendation here is about making sure that we can review the health and care pathways to make them better suited to meet rural needs. Some of the current pathways are process focused rather than outcome focused. So we see standards from Royal Colleges, for instance, that focus on numbers of clinicians present, which don't actually make sense when you're working with very small teams. So we need to make sure that we are focused on targets which are about outcomes and not internal inputs, that they're valid for rural areas. Next slide, please. Third set of recommendations relates to the structural and regulatory framework. First one, and I'm sure we'll come back to this later, seeing the place-based structures and the primary care networks within our integrated care systems as a real opportunity, and making sure that those are enabled and empowered and are able to be flexible to the needs of those specific populations. Second recommendation in this section about breaking down some of those professional silos and ensuring that we have training across health and social care, that we have new roles and careers across professions in health and care, so that we have a workforce that is better suited to meeting the needs across our future populations. And then hardwiring in some generalist skills, which are really, really important for delivery in rural health and care, where you can't have a specialist in every single area working in every single rural part of the country, particularly around general medical and surgical skills. Next slide, please. And then finally, developing those integrated services that can really provide person-centred care. And that means making sure that we have research into integrated treatments across primary, secondary health and social care, that we encourage and support pooled joint budgets, integrated health and social care budget setting. And that, most importantly, is that we empower the community and voluntary sector to really own their own health and well-being and to be active participants, because, and I think people have already said this, there is such evidence that this can really make a difference. The users, our patients, our clients are absolutely the experts, and they can bring huge advantage to being active participants within health and social care provision. And I'm sure we'll come back to that later on. So next slide, please. Thank you very much. I'll leave it there. I'm sure we'll come back in the Q&A session.
Debbie, thank you so much. That's really interesting. There's a couple of people have shared some links to reports, which we'll get those shared to the whole participants. But Debbie, somebody's asking for the full link to your APPG report, so I'm sure we can organise that before the end of the webinar. There's two questions which are very much specific to your presentation before I move on to our next presentation with Hertfordshire. And this is around, you know, the lack of access to exercise too, which could have an impact on some of those figures that you were giving around safe walking routes, access to gyms and pools in rural areas can be difficult as well.
Sorry, I missed some of what you said. Let me just go into the Q&A things. Right.
So it says often rural areas have poor access to exercise too, lack of safe walking routes, access to gyms and pools, you know, and whether that could be linked to high diabetes levels. But Sarah Tilshead would like to answer this live. Is that right?
Sarah would like to answer this question.
No, I don't. That's for Debbie.
No. Yeah.
Oh, yeah.
Yeah. Okay. No, that's absolutely true. So I've just moved from an area which was only just outside of Carlisle, but couldn't get on a bus at all, couldn't walk to anywhere, even to get a paper. I could walk the dog fine, but I couldn't go and get a paper or any other things. Yeah. So I had to always get into my car. And certainly we know that things like type 2 diabetes are very much related to weight, and if you have to always get in your car, it's not encouraging you to walk. Often people in cities actually walk far more than people in rural areas. So there's huge generalizations, but yes, access to facilities where people can exercise makes a difference. Absolutely makes a difference.
Brilliant. And there's another question about PPGs here. I'm not going to answer that because that's the next presentation, but I will come back to it. And then I suppose one thing that we might address the questions later, and Debbie, maybe you want to think a bit more about this, is how do we ensure that rural populations have equal access to the whole multidisciplinary team, including dental, optometry, I never say that word, and pharmacy.
Optometry.
Optometry, it's a word
and
I can't say.
Yeah, it's a challenge often because of just the nature of geographical access. But I think this is where our places, and in particular our primary care networks, really need to come to the fore. So not every single general practice or general dental practice can provide everything. But if those professionals work within a network cooperatively, rather than being in competition with one another, and are able to provide on each other's behalf, then you can get around some of that. So that works just as well in cities as it does in rural areas, but the impact on people living in rural areas can be phenomenal, can be much greater. So we can use, for example, the ability to have remote consultations from rural practices into places where they have access to other health professionals, whether it be physios, whether it be pharmacists, but we can also ensure that groups of practices can employ or subcontract to some more specialist members of the team, so that they can actually access them, and those professionals can move around the practices as a shared resource, whether that's a general medical practice or dental practices, optometrists, etc.
Brilliant. Thank you so much, Debbie. I just thought I'd ask those because they were quite specific to your presentation. But now we move on to another project that we're hugely proud of and excited about. And this is our project with Lauren and Heather. You're there?
Yeah.
Brilliant. Great. I can see you. So I'm going to hand over to you, and I know that in the middle of this we have a video, so we're fingers crossed that'll work well for us, which is talking about a patient participation who's involved in this project about PPGs and 155 different GP practices that we're working with you on.
Yeah, I think it's slightly less than that, but you know, we won't quibble about a few.
Let's not quibble about a few. Okay, hand over to you.
Lovely. I'll start off. Thank you for those slides. So yeah, we're really delighted to be telling you about our work with the Patient Association to support the GP practice patient groups in our area. And as the slide says, it's 135 practices across Herts and West Essex. So a little bit of background information to start off. So in one of our previous clinical commissioning group areas, we piloted back in 2019, I think. It was just pre-COVID, so the timing wasn't brilliant, an incentive scheme. And it came out of some discussions with PPG patient members, but also practices, that they would like to do more with the PPG, but actually funding was sometimes a bit of an issue. Just to do some of the activities had a cost, so arranging things like health information sessions or editing newsletters, all those had a cost. And the incentive scheme was brought in that if practices attained different levels, they would get an additional payment for that. And the incentive scheme was developed with patients, practice managers, GPs and Healthwatch. And it is now forming part of the ICB's Participation Enhanced Commissioning Framework, the ECF. So for those of you that may not be familiar about the ECF, it's locally agreed arrangement with practices, and they can sign up if they want to, and there's a little bit of money involved in those. And based on the experience we had initially in that one CCG area, the majority of practices signed up to that. So a little bit about the incentive scheme. So it's based on 3 levels: bronze, silver and gold. And the bronze is just what we would expect practices to be delivering through the core contract. So what's expected of them, of their PPGs, that is within the core funding. And then the silver and the gold is just increasing the activities that PPGs might be doing. So that is about arranging, you know, health information sessions, or it might be about editing that newsletter, or it might be about running a support group, all those kind of additional things. And depending on their kind of attainment level, depends whether they fit with silver or with gold. Can I go to the next slide, please? So just a little bit now about the approach that we took with the Patient Association. The Patient Association put together a survey for us, and it was really to gather feedback from PPGs. So that would be practices, staff and also patients, really to understand what support they needed to develop their PPGs. And we had an idea, because we you know, certainly for my role, regularly in contact with practices and patients about how their PPGs were doing. We also had some engagement sessions, and through both of those methods, we tried to understand how we could support practices in a really practical way. We established a steering group of patients and practice managers, primary care leads and health wards to really steer this project. So we would bring everything to the steering group and get their guidance on what we should do next. And out of the steering group, we also had a patient-led task and finish group, and that looked at developing models of engagement, membership approaches and other things too, and you'll be seeing a little bit about that in the video at the end of this presentation. But out of those discussions, it was agreed that we, Patients Association, would run 3 workshops for us, and the topics were very much based on the feedback that we'd got. And the first one is about just getting started. For some practices, if they had a new practice manager or a member of staff responsible for developing the group, they wanted to know how to really get started. And we looked at the benefits of the patient group for both the practice and the patients. And then for the next topic, we looked at how to effectively work in partnership, and that was about partnership between practice staff and patients, but wider than that, we're looking at more of a kind of a community engagement model. And I think one of the questions in the chat, in the question and answer section, was about our PPGs part of the wider community, and I think they absolutely are. And in our ICB area, we have a VCSFE Alliance, the Voluntary Sector Alliance, and PPGs have been invited to join that because they're seen as a really integral part of the community. And then topic 3, which is actually running just as this session finishes, and that looked to recruitment, how we kind of increase that diversity, which is always a challenge for patient groups, and how to communicate with that wider patient population. And one of the patient members of our task and finish group is actually presenting a universal membership approach, where actually every patient from the practice is a member of the PPG, unless they decide they don't want to and they cannot opt out. And that is the approach that is kind of recommended. Okay, I'm going to ask the next slide and pass on to Lauren.
Hello, yes. So obviously we want to build on the momentum that we've already got, and the the attendance and the enthusiasm, and so that we can share that. And the next step will be to evaluate the work that we've done, which will mean reviewing the workshops, and also look at other topics that people might come up with, at the steering groups and during the sessions, so that we can really build on this work that we've already been doing. And then what we're putting together is a survey which will evaluate the workshops, the ideas, the suggestions, so that we can move on with those and start to involve perhaps other surgeries and patients that haven't been involved with yet, to just keep building on it. And what we'll do is we'll put together all these things that we've learned and the resources, and we'll put those on our website. So examples like Heather was saying about the all-in approach and the buddy scheme that I know we're going to hear about perhaps later, and also put together toolkits, recordings of the workshops which are still available. We did have really good attendance for the workshops, and we know that after then lots of people did go online and who weren't able to join us view those, and they will obviously continue to be available. So that will go on our website as well. And then, like I said, we'll be working with volunteers to build on this buddy scheme that's currently being offered informally, but would be something, it's sometimes that starting point is a concern, and that's something that's been a stumbling block. So having someone that's already doing it to just hold your hand and get you started is something that was quite popular as an idea. So next slide, please. What remains for me to introduce Claire, who's been hugely involved both before and now in this project, and has been a member of the Task and Finish group, and as a GP practice patient group member, to talk to you about her involvement.
Okay, we seem to have a problem with sound on this.
Could you not hear that, Rachel?
No.
Let me try again. If it doesn't work like this, I'll try in a different setting. But if I press now, can you hear?
Patient group online workshops. Hello. I would like to explain how 4 of us from different PPGs across Hertfordshire worked together over 5 weeks to help shape the patient group online workshops. We're from West, East and North Herts with very different experiences, so you can imagine our conversations were lively and thought-provoking as we shared, discussed and debated via Zoom, telephone and email what felt important around PP membership and action. We had a clear focus as we went back and forth with the 2 Heathers, clarifying and refining our thinking on what should be included in the workshops. We wanted to provide both interesting and useful material to inspire new patient groups to get going, existing patient groups to feel well supported, and for anyone to feel able to ask for a buddy to help them build what's best for their own locality. Growing the membership and providing useful information sessions for long-term conditions such as diabetes, prostate cancer or menopause were key themes that came through. Developing a buddy system, dropping the term participation, storytelling around key pillars for success, and thinking outside the box about our audiences were really good outputs which have filtered into the workshop material. These ingredients should all help deliver inspiration and mentoring in spades to spark a revolution of patient groups across Herts and West Essex. Our input as a small Task and Finish group hopefully sowed some seeds to help a wide audience of passionate and maybe exhausted professionals and volunteers develop brilliant, robust patient group models so our NHS can continue to recover and reset. There are unanswered questions still. How to increase diversity in patient groups by maybe having a traveller or homeless person involved. How to hear from those with disabilities or mental health problems. How to help our NHS turn around public perception that maybe service is not what it used to be and GP access can be difficult for patients to navigate now. And how to help our integrated care system join even more dots so patients get even better outcomes. Thank you.
Brilliant. That who's taking? Okay, I think it's at the end of your slides, Heather. Yeah, brilliant.
Yes,
And
sorry.
yeah, so if we can just take down the slides so we can get everybody on screen. Thank you. Oh my God, there's so much in there. And can you make sure that Claire hears a huge thank you from all of us for that video, because it's not easy to do videos. And we do have a good few questions to get through, but we have enough time, I think. And I think Sarah is going to join us as well on the screen, because Sarah's been involved in a lot of these projects, and Heather Richardson, no, Heather's surname. It was the 2 Heathers that were talked about, so it's fantastic that we've been involved in all of these projects. But I think for me, you know, if I go back to the very beginning of this presentation, it's that whole thing that's coming out about looking at the whole person and living the best life that you can do. And all these projects are about trying to enable patients to have that voice. And the Patient Association really believe in patient partnership, because we believe that that is the best way that services should be designed and delivered, because they will work for patients, they'll work for healthcare professionals, and they'll make for better services and safer services. So there's a number of questions in the chat, which is talking about, and you know, what role can patients and carers have on an ICB or ICS? Lauren, I'm wondering if you could come in on that one, and how, rather than it being always maybe charities or, you know, Patient Association, Health Watch, how can individual patients get involved?
Do you want me to take this, Lauren?
Yes, I can chip in as well, but yeah, Heather's the best person for this job.
Okay, cool.
Well, I wouldn't say I'm necessarily the best person, because
we'll take you as the best person.
Yeah, well, yeah. So I mean, I can only talk obviously for Herts and West Essex ICB, and we're a very new organisation. And we're starting to build what, and I think in the question and answer box, somebody said CCGs no longer exist, and you're absolutely right, they don't. And we're trying to take all the good things that happened within individual CCGs and bring them into one organisation. Now, I can only answer for Herts and West Essex. We're really not there yet. We're starting to build those networks again. They won't be the same as what CCGs had, but I think they will still be effective. Our approach is to build those networks within our PPGs. The ICB is committed to really helping PPGs develop their presence, their membership, so they have a really active voice within the ICB. Other ICBs might, ICSs might take a completely different approach, but that's all I can say at the moment. That's our approach.
Fantastic, thank you. Does anyone else have anything to add to that, Debbie, in terms of getting involved in your community work as well?
What I would say, and many of us who have been around for a while have seen lots of moving the deck chairs around and the NHS furniture and saying, oh, here we go again. But one would hope that each time we try it, we get a bit better at it. And with a glass half full approach, I think we should see this as an opportunity, but we need to make sure that we don't reinvent the wheel and we don't throw the baby out with the bathwater. So I think what Heather said is absolutely right. We need to build on existing structures. Somebody else was saying in the chat room about, you know, it's often we forget the community organisations within this, and we get the larger organisations engaging rather than individual patients or small groups like tenants associations or mother and toddler groups who've got real specific issues. And that's where I think that we should push to have places in particular, rather than ICPs, which may be a bit distant from patients and communities. I think we would push for places, particularly through the local authorities who've already got community development workers, to use community development approaches of community development workers to really build up networks so that individuals and very small groups can engage. But I would say, don't try and look for the sort of one person who's going to represent you on an ICB, on an integrated care board within your system. Work at your local level, use your existing mechanisms, make a noise, find out who's responsible for engagement and involvement, get them on side. Somebody once said to me, somebody I worked with who was a community development worker said, you know, people have never got axes to grind, they've got opinions and a wealth of experience to share. So don't feel that you're being annoying. Get in there, make a noise, find out who the movers and shakers are and go for it. I would say use your primary care networks, use your GP patient participation groups, get together with other people who share your interest and priorities, and go for it.
So on the making a noise, I'm going to come over to Helen, because myself and Helen often like to make a bit of a noise about patient power and where it sits. But Helen, you know, you've been really successful in getting your voice heard, and it's a very powerful voice. So what advice would you give to patients and the public about getting more involved? Because it is difficult.
It is, but I can't really follow Debbie's comments because I completely and utterly agree with everything she said. I have always done some sort of voluntary work. I spent a lot of time supporting families with children with disabilities and special needs. And for me, it was about wanting to give back into a system. So I had the willingness and I had some time, and it was, for me, it was exactly as Debbie said. It was like, where can I make a difference? And just because one door shut in my face didn't mean that I then walked away and thought I can't make a difference. Actually, I needed a little bit of tenacity, I needed a bit of a thick skin, and I needed to just keep poking until I found the right place. Now for me, it was around personalised care, because that had been the big difference made in my life. I found who what was then the CCG lead for personalised care back at, you know, when the long-term plan was produced, and I got in touch, and they just so happened to be putting this group together. They invited us and we moved on. I've looked at doing other things and the doors have been firmly slammed in my face. You know, we don't do this here, we don't do so. It's not perfect. You know, Nottinghamshire is doing a really great job. You know, the personalised care work that happens that is truly co-produced is an exemplar, it's exceptional. The wider ICS and ICB is trying to put together an all-encompassing strategy. It's still in its early days. For me, there's a lot of work to be done. Does that mean that we shouldn't keep trying? No, absolutely not. And I think, you know, hospitals often have patient groups, if that's where you've got the time. I love the idea about working with mum and toddler groups, going and listening to school councils, that sort of thing, because we often forget our children and young people. And Rachel will say, I do tend to get on a bit of a soapbox around our children and young people who are often missed, and we don't listen to them. You know, they've got great views and great value. As system leads, we need to encourage some of our system leads, or even our GPs, to go and meet with some of these children and young people and hear their opinions. But, you know, there are often little groups around. You know, if you go to your local library, I've seen some advertised in my local supermarket. You know, get out there, have a look around, have a look on websites. If you can't find it, you can usually Google the CEO of an organisation, of your ICB or your ICS, and your place-based partnership or your local city council. You know, email them, introduce yourself, say, this is who I am, this is what I want to do. I want to make a difference. I want to improve things for all people, not just a select few. And just keep going. I know Carol had said, you know, it can be really difficult. Sadly for me, there is a bit of a postcode lottery still going on now, even though the ICSs are now nearly 6 months into their fruition and their journey. That doesn't mean they've got it all. But it is worth knowing that there is statutory guidance out there to support working with people and communities. They cannot ignore us. You know, people power is there. We can make a difference. And the more of us that stand up and want to be counted, the bigger that wave comes. But it's worth knowing that there is that statutory guidance and expectation that we are going to want to be involved. And I know that Rachel's done webinars before on basically people power and getting involved and making a difference.
Brilliant, Helen. And actually, we must put a link to that statutory guidance and that piece of work that we all were involved in around working with ICBs, which I think will help some of the questions around the different levels as well. So people power, patient power, like just hugely important and hugely important at this stage as we rebuild services and develop new services. But there was questions in the chat, and I think it was around the diversity issue. And Sarah, I'm going to come to you on this one, and Sophie, I'm going to come to you with a question then. But Sarah, that way of getting involved with those voices that sometimes don't get involved, and Claire on the video talked about that as well, you know, getting your refugee voice, your homeless voice, getting all of these people involved in this development of services. Do you have any advice for people on how they might do that?
Yeah, so I'm head of patient partnership at the Patients Association, and one of the things that we have at the Patients Association is a lived experience advisory panel, which is called Patient Voices Matter, and the group chose that name themselves. We didn't choose it, and that group we recruited from kind of all walks of life to make sure that we really were representing the voices of as many patients as we could. Obviously, we can't represent every single person, but we really tried to get a kind of a broad array of people, and they've come together, and as I said, they come from very different backgrounds, but they are experiencing very similar types of experiences. And then, so I think that is important to ensure that you are bringing different people in. And then part of my role is to ensure that we are bringing different voices in. So that sees me going to different types of organisations and ensuring that they know about us and we know about them, and we are working in partnership with them. And the more that they know about the Patients Association, then hopefully they will be more involved with us, and then we can do more patient partnership. And we really are hearing from as many voices, from as many different communities as possible.
Brilliant. And Sophie, you've done a lot of work in different ICSs, and there's a couple of questions in the chat about people feeling that there's barriers in place. And you know, there's one particular comment in there saying, I actually felt like I'm going to walk away from it because I'm not being heard. And I know that you've done a lot of work. What would you advise on things?
Yeah, I have done a lot of work, not within these ICSs, these current structures. I just need to make that clear, but certainly in their predecessors, which look very similar in many ways. What I would say to that particular person who was questioning is that I don't necessarily think it is always that valuable to look for sitting around a board. It can be an extremely dull experience. With things not really very relevant necessarily to the things that the person may want to talk about. I think it would be far better to find other mechanisms for engagement, because I think being attached to boards can end up being tokenistic. People think they've ticked the box because they've got a patient around the board, and that's not the way it works at all. So I would look for other mechanisms, and there are other mechanisms, and I appreciate what that person was saying about some practices don't want patient participation groups. Fine, move to the primary care network then, because I think that they will then encourage that practice to have a patient participation group if you want to talk about general practice issues. If you're interested in hospital related issues, becoming a governor is a good way to do that, and hospitals are often looking for governors, and it's a great way of getting involved, because what the work that trusts undertake with their governor bodies tends to be in relation to the things that the governors want to talk about. You know, it's their agenda rather than a board agenda, which is often not what individuals want to talk about at all. And these other mechanisms, so, you know, going via your local health watch, going via some voluntary sector groups, talking to your local authority. And I think, Helen, you were very articulately saying about how you will find that doors will close on your face, and you will find that there are other times where you get to engage with somebody who you can chime with and who embraces your expertise, as somebody who is bringing real added value to delivery of health and care and sees you as an expert in it. So keep trying, don't give up. I know it can be discouraging, and you know, from my personal experience as a patient and as a carer, I've had difficulties too. It's not, I know it's not plain sailing, but I would say go for it, but don't look to sit on an ICB. It will bore you half to death, and not
so
actually
keep up the good fight is what you're saying, and get involved in there. Sophie, you know, from the Patient Information Forum, you know, you've done a lot of work. I've seen some really good examples in there about getting young people involved, you know, and again building on getting that more diverse voice into ICBs.
And I mean, what we've just heard is you've got to look some notes there, you know, like you need to be tenacious, you've got to keep poking, you've had the door slammed in your face. Well, a lot of people will give up, you know, a lot of people that you really want to hear from will give up at that point. And if we really want to get people involved, we need to make it easy for them to take part. We need to be reaching out into those communities that we're not reaching currently. Some of the work that we did earlier around the NHS Assembly, Nottinghamshire particularly, you know, we went out to migrant community groups, we asked them what their barriers were, what they needed to know. We went out to carers, you know, some carers, and actually some people's confidence is really low after they have been caring for a long time and they've been out of the workforce. So the idea of actually being as tenacious, you've got to be quite a strong personality to keep going in that. Well, you've really got to know your way around the system and not be scared to be a complete pain in the backside. And that's going to exclude a lot of people. So I think it is about going out to people, using, you know, working with communities, not against them, find what's in it for them to participate. Because if we are really going to focus on health inequalities, we need to be engaging these people. So we have got some guidance on co-production on our website, which is mostly about health information, but actually the principles are identical. For a lot of people as well, if you want them to take part in these things, you need to remunerate them. They're going to be, you know, we're living in a cost of living crisis. You want people to take time out of their working day or travel to take part in groups. We need to be covering their time. We need to value their expertise in exactly the same way that we would value that of a healthcare professional, because actually they, you know, service users will give you the information that you need to reach them, to make those services work for them, to get all these efficiencies that the NHS wants at the moment. We can't do that without taking people with us.
No, absolutely. And I think your point around, you know, you have to feel like you have the power. And myself and Helen and Sarah spent a lot of time talking about how that power and how it is the healthcare professional that needs to have the confidence to give that power. And I think there was a conversation earlier on in the chat where it was an individual, I'm assuming they're a healthcare professional, said the shock sometimes on a patient's face when they start their meeting with them going, you know, what's important to you, what matters to you. And we've done a huge piece of work around shared decision making in that field, and we did a survey with healthcare professionals to look at what the barriers might be. But I have to say that overall, from a healthcare professional point of view, they really wanted to do shared decision making, and you know, they found time. But with a lot of more specialist nurses in particular, they were saying, well, actually, you save that time in the long run, because you start with that, what matters to you and what's important to you. And Helen known about Carl and football, and that's what he loves, and that's important. And, you know, to have that all the way through the journey. But I do think that we have to do, as a team and as a society, do so much more work in really understanding, you know, the voices we need to hear from are Helen's voice, but they're also the voice of that person who, you know, isn't going to do that. And how do you proactively, would you suggest, Heather, or anyone else on the call, how would you proactively engage those communities? Now, Sarah's given some examples.
Yes, sorry, that is a challenge, isn't it, in terms of our challenge? It's not that community's challenge, you know, they're there, they're ready for us. So all I can talk about really is what we've done particularly in our local area, and I think Helen referred to kind of local place. Well, you know, what's a place? It's a local area. And people have a relationship with that. And I think when, you know, if you go and speak to people in whatever way that you want to on a particular topic, or more generally, people will share their experience with you. And I think it is for us to go out to speak to people and find out what they want, and of course that might be on a particular thing that we're going to be engaging on, but it might be more general. It's about going out to you know, kind of PPGs to speak with them directly. It's not expecting everybody to come to us, and as Debbie mentioned, it isn't for everybody to want to sit around a board meeting. I mean, it doesn't necessarily achieve what you want to achieve, and that is getting the voice of the patient and the carer integral to everything you do. I have noticed, I've been employed in this role for, well, too long, we're 16 or 17 years, and I have noticed a difference. I have noticed that health professionals are much more open to hearing from their patients and their carers, because they know how important that perspective is. You cannot deliver a quality service without knowing what it feels like to receive it, because that is the end point in a way. So I think we, you know, we have to go out, and we have done that in the past. You know, we've gone out to speak with people who may be homeless. We've worked with our Gypsy and Traveller community. What we haven't done, I don't think, is make that something that is more ongoing, because you're reliant on people in that place at that time to do that piece of work. And because the NHS changed so regularly in terms of personnel, but obviously also structures, sometimes those relationships are lost, and you then have to build them again. So I think that's a challenge for us, but that's my view. You know, we have to get out into our community.
Absolutely. And then there's the messages there saying, you know, go to the hairdressers, go to where people are at, go to the high street. And we had a session on Monday morning around shared decision making, another event during our patient partnership week, and it was with Realistic Scotland, Realistic Medicine in Scotland. And the lovely thing really excited me, they showed us loads of pictures of how they were engaging, and at one stage they were in the middle of their you know, market, and they're going around and asking the public what they think of shared decision making. And I thought, my God, that's just so powerful, because we do need to get out there more. You know, we're a small organisation, so I'm forever challenging myself as to how we can do that. But there's another part in the question where people are talking about sorry, Debbie, did you want to come in there on that point?
Sorry, wrong button then. No, I absolutely agree, Rachel, Heather, with what you've both been saying. Yes, I think people should make a noise, but I think that health and care have a responsibility, and we need to go out there. We shouldn't expect people to come to us, sit around a table. We need to go out with people who have the right skills to go and talk to existing groups on their own territory about the things that are important to them. And it might be that it takes us by surprise and it's not the things that we think are important at all. It might be dog poo on the streets. It might be something completely different, you know, to what we think the priorities are. 25 years ago in Newcastle, nothing to do with rural areas, we used a community development approach to engage with patients and communities, and those were very small groups, and it had a snowballing effect, and we ended up employing community development workers across the city who had a continuous dialogue that fed through into the health and care commissioners and providers, including the general practices. And there's this ongoing dialogue between members of the community, whether they were, you know, part of a tiny little group. We deliberately sought out those most marginalized groups. So all the community development principles. And I think that that would be worth lobbying to make sure that every ICB and every place within the integrated care systems uses community development principles to actively and continuously have an ongoing dialogue with their communities.
Absolutely, because I think it's about understanding that people have a lot of different pressures in their lives, and that we do really need a health and wellbeing strategy that covers all aspects of life. And you and I see that, Helen, in all the work that we do through the NHS Assembly. The impact on somebody in there, somebody in the question is it's talking about, actually, and we did talk about cost of living. If you're struggling to just keep your heating on and you're struggling to just make ends meet, how do we make it, but actually want to be involved? We need to make it easier for people to get involved, and to do that we need to be in their place and we need to be part of their community. So when I did community development years ago, it was about, I tracked the streets and went to different women organisations and became part of their communities, because we can't just say, hey, we want to talk to you. We've got to become part. And Helen, I don't know if there's something else you want to add to that part of the conversation, because I think you've been involved as a patient. One of the questions on there was saying, well, look, we're talking about listening, we're talking about lobbying. Actually, how do we know that people have listened? How do we know? Because I think one of our reports years ago was talked about the fact that sometimes you get involved and sometimes it's okay not to take on the ideas because maybe they're not going to work in the way that we need to, but it's about that communication, isn't it?
Yeah, absolutely. And it's interesting listening to the discussions. There are an increasing number of us that are patient leaders in our different, they used to be called, I think, lay people. Well, I always thought that was somebody that talked in a pulpit, so I got very confused for a very long time. And actually, that's a really fundamental point. Language matters. Why does the NHS and all of these different things have words that are completely meaningless to people like me? And, that is a barrier to working with those people that are easily ignored in our different communities. I have a responsibility as somebody that has a voice now to go out into my community and bring people with me. I know I'll have been successful when I've recruited another 10 people behind me, which allows me to step out and other people to step in. It's not for me as a patient leader. I don't want and should never want to have the glory and the power that comes with doing what I do. It's got to be about people coming behind me that have even more up to date and different opinions and different ideas about what works or doesn't work in our community. We should always be looking at what next. I think it can be really, really difficult sometimes where, Rachel and I have sat in something recently where we wanted to deliver a message and that message wasn't necessarily heard in the way that we really, really hoped. And yeah, that hurt. That really, really hurt. But actually, increasingly I'm finding there is more positivity. The work that we've done around musculoskeletal work with Sophie and Sarah within Nottingham is one example of many of some great pieces of work that have been done, that have been truly co-produced, where a difference has been made. Somebody asked in the chat, where was the ICB within all of these conversations we had? They pretty much sat in the corner, listened and learned through the process. They didn't try to battle us. They didn't try to insist we saw it their way. Actually, they used it as a real opportunity. And those opportunities are growing. They really, really are growing. And I think as more people engage with webinars like this and want to learn more and want to make a difference, change will happen. It's different to 10 years ago when I first started sort of dipping my toe into some of this, when it was very definitely, well, you're just a carer and actually you haven't got a degree, so I'm not really sure you can play a part. It's taken me time, and actually our local system has invested time in me to build up my skills, my knowledge and my confidence by putting me on some different training opportunities and coming alongside me to support me to learn and deliver in a different way. And the system has to invest. Sophie talked about the fact that I can't give all my time for free. I can't afford to travel around for nothing. I need at very base level my expenses to be covered. But you know, so I'm just seeing somebody's dress code, healthcare professionals looking, you know, tidy. Yes, but if you're going out into the community, I don't want you to turn up looking neat and tidy if actually I'm going to go out to my homeless community or my gypsy traveller community who dress very differently to the way I certainly am dressed today. We need to try and break down those barriers where possible. Sorry, I've waffled a little bit. As always, Rachel, I've got going. I'm
you never waffle. You only talk with passion. Now, there's a few comments in here, and it's very much about shared decision making. And I just want to reach out to somebody to say that we'd love to catch up with you afterwards, because I think that, you know, there was a big conversation this morning with Patient Safety Commissioner about psychological safety and staff safety and patient safety and the link between both of those. And because, you know, if somebody's talking in the Q&A about feeling that their voice isn't being heard, so I'm going to send you a message there because I'd like to listen to that voice more and talk about some of the stuff that happened this morning, because that is a very difficult position in terms of shared decision making, that you're not working with your healthcare professionals not working well with you. So Maya has put in a copy of our jargon busting dictionary, because that was something that we had to create when we started our lived experience advisory panel, and I don't think I speak in jargon, and then I realized that I did. So I think we all have to check ourselves all the time that we don't become part of that system that talks about ICSs, ICBs, you know, so we talk in plain language. So we are coming very much to the end, and I can't believe that we've gone through an hour and a half. I think, you know, there's some lovely comments in the chat about how much people have learned and great ideas. And there's a lady called Sarah on here who I remember seeing in the Evening Standard when I first started at the Patients Association, and seeing her article about how she did patient partnership, and I thought, no, we can do this, we can do patient partnership. But you know, we still have a long road, and she talks in the chat, in the messaging, about her heart beating every time she went into the room. And for me, that's a massive thing. Whether you're going into your GP surgery or you're going into a meeting, you're going into somebody else's environment, you're at a disadvantage altogether. So I suppose my call, and I don't know if anything else, it's that healthcare professionals and those people working in that kind of professional landscape realize that that's how we feel when we come into these rooms. I don't know, Helen or anyone else, because we have 2 minutes in which we have to finish. So I'm going to quickly go around the room and see, do you have one takeaway? So Sophie.
Yeah, I think this last bit of the discussion, use plain language all the time in all of those settings. You know, when you're writing letters to ask people to, or in anything that you're doing, it's not just about health information and appointments. We should be using plain language all the time, because just the system and understanding the change and all this terminology is really baffling for people. I also think that point about how you dress is important as well. So you break down some of these power dynamics. We heard very clearly from children and young people when we did some work that lanyards can be a problem. Just something people wear in their everyday life, like a lanyard for somebody who's been in care or who's been in the criminal justice system, can be a real barrier. So actually some of these barriers are not always something you're going to notice, but I think that comes from listening to people. Fundamentally listen to people.
Brilliant. Okay, we've got 30 seconds and you've each got one thing quickly to say. But the rest of our team on here today, the chat is open again because we can now manage the chat as well. So anything you want to put in there as takeaway or things you want us to consider to do differently. We're just running over. Heather, anything quickly from you?
Yeah, I think I'm taking away that even though I think I knew the challenges sometimes about getting involved, and some of those barriers that are in place that we may not really be aware of. So it's about making sure that we speak to people and find out what those barriers are.
Brilliant. Sarah?
Yeah, as well as different places, different neighbourhoods, different ICSs being very different. Every person is very different. So I think if people are engaging with you and want to work in partnership, then ensure that you're working with them in the way that they want to be worked with. Or worked doesn't sound right, but how the way that they want to be engaged with you. So you are, it's essentially personalised partnership. So really think about how they want to be involved with you.
Brilliant. And Helen?
Me, as a patient, know that you've got value, know that your lived experience matters. It's not something to be ashamed or hide away from. Actually, you've got so much to offer. Please offer it.
Yeah, you rock, Helen. And Debbie?
Well, firstly, I think I'm sorry to hear that so many people are experiencing so many difficulties in engaging and knocking on doors and not having them open to them. So an apology should move faster than that. But my advice would be find a champion who's inside the system, stick close to them, make a noise and keep making it.
Brilliant. Fantastic advice. Well, listen, thank you all so much. And thank you so much to panelists. Now, there is a session happening. Tomorrow's not Friday. There's a session on Friday on engaging with the system, which is on our website. And some of the people on this call today might actually really like to attend that, because it's going to look very much about families' experiences after serious instances, how they addressed it and how healthcare professionals worked with them. So if you want the link for that, it's on our website. So please do sign up. I've really enjoyed today. Thank you so much.